Hello and welcome to the Doc Podcast. I'm your host, Dr. Mike DeLuke, and it's my mission to help you lead a happier, healthier, and more prosperous life, both personally and professionally. Hello and welcome to this episode of the Doc Podcast. Today, I am joined by three guests who are the founders of Sound Health and the Sonu Band, which is one of the more innovative products I've come across in the airway and sleep health space. And the format of this show is going to be a little bit different, as to coordinate all of our busy schedules, we had to break the episode up into two separate segments. In the first segment, I sit down with Dr. Paramesh Gopi, founder and CEO of Sound Health. Dr. Gopi is a tech industry veteran who pioneered wireless connectivity in mobile devices and wearables and was recognized as one of Bloomberg's top turnaround CEOs. But it was his own lifelong battle with allergies and chronic sinusitis, which I can certainly relate to, that ultimately led him down a very different path, one that resulted in the world's first FDA-approved AI wearable with the efficiency of a nasal steroid, which they brought to market in 2024. His story is a fascinating one, and we'll dig into the design and engineering behind the Sonu Band in the first part of our conversation. I'll then be joined by Drs. Peter Hwang and Bryant Lin, who are going to take us on a deeper dive into the science behind this amazing technology. Dr. Hwang is Vice Chair of Clinical Affairs of Otolaryngology at Stanford, a past president of the American Rhinologic Society, and a nationally recognized expert in endoscopic sinus surgery and innovative devices for sinus disease. If anyone can explain why this technology works, it is Dr. Hwang. Dr. Lin is a primary care physician, educator, and researcher at Stanford, with degrees in electrical engineering and computer science from MIT and an MD from Tufts, a combination that gives him a uniquely powerful lens on where medicine and technology intersect. He serves as co-founder and head of product development and clinical affairs at Sound Health. Together, we are going to uncover how acoustic resonance therapy uses sound waves to relieve nasal congestion and improve airway patency, how AI-guided facial screening and voice analytics are being used to assess nasal passageway anatomy and guide treatment, the concept of theragnostics, which is using diagnostics to maximize treatment efficiency and efficacy, the critical role of the vagus nerve in all of this, and my own personal experience as a user of the Sonu Band. We'll also give you a glimpse into some of the exciting future innovations the Sound Health team is working on and the additional applications they have on the horizon. I also want to mention that I am not in any way financially affiliated with Sound Health or the Sonu Band, but I thought it was something I would share with the Doc Podcast audience so that you all can decide if it is something that could possibly help you and or your patients. So without further ado, let's get on to today's episode with Drs. Gopi, Hwang, and Lin. Enjoy the show, everybody. Welcome to Doc Podcast, Paramesh.
Thank you so much. It's a pleasure to be here today.
Really happy to have you on. I'm excited to talk to you about this product. I have been using the product for the past, when did we first speak? Maybe, a month and a half or so ago.
Almost a month and a half ago. Yeah,
and I've been using it, and I'll talk a little bit more about that as we go. I don't want to spoil that quite up front. And I haven't even told you yet about that. So just to
I would love to hear it. Yeah, absolutely.
So before we get into the product and the company and more in-depth on the engineering and what you all are doing, especially as it pertains to patient health and airway-related patient health, how did you get here? How did you get to this point? Just for the audience who heard the intro, your background is not in dentistry or medicine per se. It's in the engineering side. So tell us a little bit about that.
Yeah, no. I think it's a really apropos way to start things. So I'm a PhD in electrical engineering and computer science by training. This is my fourth entrepreneurial venture. The last company I ran built the first high performance devices for data centers. We hear data centers all day long. We pioneered the use of low powered chips in data centers before AI became a big deal. And when I sold that company in 2018, it was a very nice exit for everybody involved. I thought I could, take like a year and just recover from that big lift. But I ended up falling sick, and that was 2019, the year before the pandemic. And the sickness, believe it or not, prevented me from eating because I had such multiple sinus infections that occurred in a row, to the point where it was almost 60 to 90 days of antibiotic therapy.
Yeah. Wow.
And you can imagine, what that takes. Now, to be fair, I've always had allergies my whole life. I have been a Flonase user. I've been a sinus rinse user, but most importantly, I've done antibiotics probably every quarter. When I used to travel to Asia, I used to pop antibiotics on the plane because I knew that when I would get off, the pressurization and the long flight would inevitably get me an infection, and it would just completely get in the way of work, right?
Yep.
So anyway, I think my bad habits and my airway caught up to me late in life. And it turns out that that was very, very important, because after multiple runs of antibiotics, I had to then be charted off to Stanford. And my dentist, so this is where the story gets really, it's very interesting. I was actually referred by my dental professional provider through a concierge doctor that I had. And they both referred me to Dr. Peter Hwang. And Peter is the head of the Stanford Sinus Center. If you go look for rhinology in the books, he wrote the book on rhinology. So he's one of the world's leading rhinologists. And basically, he's basically at a point where he sees the people that are intractable in terms of getting help. And to Peter's credit, he's very conservative. So he looked at my CTs. And I actually went to him because I couldn't bite. And I said, I really need help here. And his answer to me was, I'm not going to operate on you. Which, by the way, really threw me for a loop, because I'm like, hey, I've suffered with this my entire life. And I need help to make sure that this state changes, at least in a semi-permanent way, where this is not happening to me every 3 months. In any event, so Peter actually took the time he looked at my CTs and he showed me my anatomy, and he said, well, if I operate on you, I'm not going to be able to guarantee you that you're going to feel better. And you're going to come back 6 months later and say, you know what? You said you were going to do all this work on me. You did all this work. And guess what? I feel the same stuff is coming back. Right. And so, that really, honestly, to go to a surgeon of that caliber and hear from him that, I want to be conservative with you because there is nothing anatomically deficient with you that's causing this, and we need to get to a more sustainable solution. I was like, wow, this is a very different way of thinking. And so, as with everything that happens in the Valley, he told me to meet him after office hours for coffee, and literally brought my CT scans on his computer. And he introduced me to Dr. Bryant Lin, who's the head of the internal medicine team at Stanford that he works with, and he said, we've been working on an idea. Would you like to hear about it? I said, sure. I'll do anything. I don't want to do Flonase. I don't want to do sinus rinse. I don't want to do antibiotics. So literally, he looked at my sinuses and he says, you're an engineer. And Bryant is an engineer. Bryant's an MIT engineer turned doctor. And they'd been working on using sound waves, specifically vibration, to be able to open and keep the nasal passages open for sustained periods of time. And I happened to be the first patient that they tried it on. So really, it was a confluence of, I'm calling it deep surgical expertise, very experienced med tech, and Bryant had done the first cryoablation company that got sold to Stryker. So both Peter and Bryant had been involved with, I think, the top 3 or 4 big ENT companies at their inceptual stages. So they really understood the need for something non-invasive and sustainable. And I became the guinea pig in a good way, right? So, that then started off the whole work. And I'll leave you with this picture so that, for your viewers, after the meeting was over, they gave me a bunch of numbers and volumes. They gave me a bunch of toothbrushes, the Sonicare toothbrushes reprogrammed, and a bunch of buzzers. So I look like a modern day Frankenstein in my bathroom, putting this on for 5 to 8 minutes, 3 times a day. And believe me, it's so weird. After 3 days, he said, stop all the medication. I want you to wash everything out.
Wow.
Use this for a week and tell me if it doesn't work. And the thing that I was like, if it were not Peter and Brian telling me this at that time, I wouldn't have believed it.
Right. Never would have done it. Right.
Yeah. I'm like, what the heck? But the fact that they could explain the physics, and what really got to me was, hey, most of your skull and your sinus cavities are air-filled bony structures. Mm-hmm. And by the way, if they are not filled with air and filled with mucus, all your nitric oxide production is gone. So whatever healing process the body has naturally endowed you with is compromised because you're not breathing through your nose. So that got me. And then the other thing that got me was they actually calculated all of these volumes in front of me. They actually looked at the physics of my CT scan. They said, here's how we're going to model your sinus. So, I mean, they'd done obviously a lot of work before I got involved in this, right? And it's funny, I asked them, when did this whole idea start? And it actually, when Peter gets on and then you talk to him, you should ask him that, because he has a very fascinating story. As a resident at UCSF in the 90s, his attending asked him to figure out why there was such a low incidence of rhinosinusitis and rhinitis and breathing issues, nasal breathing issues, with people who are singers and who are choral performers. So the inceptual thought came from that study. And it's a large study done in Sweden by Karolinska, very, very famous study, right? Which is where all the humming literature and all the singing literature, all of that originated from that study, right? And so, that's how we got started. And by the way, for me, it's been a game changer. I have not used a single antibiotic or a spray in 5 years.
Wow.
So for me personally, it's like, if I don't use it at least 3 times or 4 times a week, I can start to see my, especially if I'm in large temperature gradients. I'll give you, Northern California is an interesting place. We go from sleet in the morning to 60 degrees in the afternoon. And, there's a lot of temperature equalization that happens. We see pollens because of all the climate around us. In any event, it's been a game changer for me. I don't have to deal with sprays. I don't have to deal with any, and now here we are, 10 studies later, 2 FDA clearances later. We actually have something that a toolbox is worthy of a good ENT toolbox or dentist toolbox. We have really good data science in a wearable that's equivalent to a steroid. Right? And that to me is the biggest contribution that I think Peter and Bryant and we've made now over the last 5 years, right? It's a really well studied. It's very fascinating what we're going to do with it in the future. But the fact that we can actually precisely target your anatomy and vibrate the sinuses and the nasal nerves that actually control the actual nasal response is a big deal. Plus, there's no side effects. We've got over 14,000 people on it now. We're growing 4x year on year. We're now standard of care at Cedars-Sinai. We're going to be soon standard of care we're standard of care at the California VA. So really, I think we built the technology grounds up with really good science.
Yeah. Oh, that's so cool. I love hearing about that because there's actually a lot of parallels to my life. I don't know that I've ever mentioned this to you. I'm a chronic sinusitis sufferer. I have been through 2 sinus surgeries, and it's all due to allergies in my case as well. I have suffered mightily, as you're talking about quarterly antibiotics. That was my life for many, many years with concomitant corticosteroids and tapers. And I mean, I can't even count how many times I've been on prednisone. And for me, it was really bad because I now know I'm not pen allergic, but for a long time they thought I was. Thankfully, my allergist said, let's do a challenge on you and see, because a lot of people who thought they were as children are not as adults. Right. But up till that point, they had been thinking I was pen allergic. So they were treating me with heavy dose, broad spectrum fluoroquinolones, concomitant with steroid, which leads to a lot of times ligament tears and joint problems, which thank God I didn't suffer from, as much as I even put my body through a lot of abuse physically. Somehow I didn't have any of those issues, but it was a lot. And, I'd be sitting at the chair all day, and with my head down Paramesh, it felt like my head was going to explode all the time. I mean, I would come home and we had little kids at the time. And sometimes I would literally just lay down on the floor and let them kind of crawl on me. And I'd be like, I just couldn't even think. It was excruciating. And as you said, I had the one surgery, and within 6 months, as you alluded to, and Dr. Hwang had said, I was back on antibiotics, and then I had another one a couple of years later, and that one within 6 weeks, I was back on antibiotics again. And really, it was atopy based, it was allergy based, and I finally got my allergies under control. And what saved me at that point was a nasal irrigation with budesonide, my ENT at the time, right? For those of you who are listening, very much had a big thumbs up for that. It was nasal irrigation with budesonide because it was somewhat experimental. This is going back like 2010. And my ENT, who I worked with on patients and I had a great working relationship with because I was starting to understand airway in my own patients, he said, well, we can kind of try this. We're going to take the budesonide that you use in a nebulizer and we're going to put it into a saline sinus rinse. And so that ended up helping me. And then I got my allergies more under control. But I still always struggle with it. It's never gone, right? It's never like, I rely on the nasal steroids still and have to use that for nasal passageway patency. So that was interesting. And the other thing was how you turned your issues, your health issues, and kind of by a bit luck and a bit opportunity, and as the old saying, luck being preparation meeting opportunity, you had the training and the knowledge and the engineering side. You had this health issue that led you to meet with Brian and Peter. And next thing you know, you've launched this company that's helping now tens of thousands, and it's going to be even exponentially more than that. I'm confident. Yep. I had a similar thing where because of my sinus issues, I got more integrated with the ENT community, and that led me to talk to ENTs more about airway. And then I started realizing, and they started asking me questions about kids and adenoidectomies, and I didn't really know much about it. And that all led to me understanding a lot more about, more broadly speaking, the respiratory part of the craniofacial respiratory complex. I just thought of it as, right? My role was teeth, and yeah, we can kind of move bones a little bit with some things, but I didn't really attach it to airway until I was going through this, looking at my own CT scans, talking to the ENTs about it, and just kind of like your interaction with Peter and Bryant, they started talking to you about that more, and you started to say, well, yeah, I'm going through all this. Let's see what we can do for others as well. So as you're saying, like, it's just so crazy how our experiences.
I think you're an empath. That's
I would agree.
The one thing that I will tell you, that talking to you, it's very resonant with me, because you're not a doctor and a physician and a surgeon that just operates on people to fix a cosmetic issue, but you're a real empath, right? I mean, I think that's, to me, I'm sorry to interrupt, but that's the kind of thing that Peter and Bryant, and when I hear your story, it really resonates with me, because the number of people that I hear about who've gone through this stuff, and just to be clear, we're not curing surgically, issues. We can't do that.
Right.
That's
right. Exactly.
Clear, right?
Yep.
But to your point, to manage this in a way with some, depth of knowledge and some level of, I'll call it, non-pharma intervention is so critical. I mean, when I hear you, I was like, oh my God, I could just imagine what you went through. And you're doing all this stuff, right? So.
Hey, everybody. Quick question. How many kids are you seeing who are mouth breathing, snoring, not sleeping well, maybe struggling with focus or behavior in school? You know something's off, but we're never taught how to treat these patients early. So we wait for more teeth, wait for maturity, wait for the permanent dentition. Meanwhile, that child keeps suffering. Well, it's time to change that paradigm, which is why I've partnered with Dr. Daniel Camacho to launch the Early Orthodontic Treatment Comprehensive, a hands-on 2-day immersive experience in Fort Lauderdale, Florida, this November 13th and 14th. You'll learn to identify these patients early, read CBCT images, coordinate with medical and OMT colleagues, and deliver proactive dentofacial orthopedic treatment. You'll study real cases, then watch it done live on actual patients. So you'll return home with the confidence needed to implement it in your practice on day one. And the support doesn't stop there. The registration fee includes my full 26-hour online course, a live remote case review in spring 2027, and a full year of discounted coaching. And if you enroll by May 31st, you can save $1,000 off the registration fee. We're keeping this intimate, just 20 docs. So click the link in the show notes and grab your spot before it's sold out. We'll see you in Fort Lauderdale. Yeah. And how that led me to be more aware of airway. And I'm convinced one of the reasons I invested in low-dose CBCT imaging well before it was in vogue, it was in 2014 that I first put my first machine in, was because I was looking at these CTs in my own head and understanding, wait a minute, there's a lot of anatomy there that's directly related to craniofacial growth and development. And a lot of people in the orthodontic community still like to try to dispute that the way we breathe changes the way the face grows. I don't understand. There's so much literature that shows that it's related in children. Even so, let's even say it doesn't impact, hypothetically speaking, but it does. Let's just pretend that it has no impact. The way we breathe has no impact on the way the face grows. We know so much about the neurocognitive deficits and the behavioral issues and the cardiovascular issues, and then the development into adult sleep issues. And we'll talk a little bit more about those today too, but how many things this impacts the way we breathe through our noses. And you alluded to it, the incorporation of nitric oxide into the air to assist with not only purification and sterilization of the air before it goes down into our lungs, but also the vasodilatory effect of it.
Exactly.
Right? And to increase the perfusion of the tissues through the bronchodilation that happens. So there are all these impacts of why we're supposed to breathe through our noses. Why don't you think, what have you, since you're in this space, what have you heard from people, or do you hear, as much as I hear from people in my world, that nasal breathing isn't a big deal? It's like, hey, open your mouth, no big deal. I mean, what have you seen on that?
No, I think you have a great, that's a great question. And I'll tell you something, and it's funny you should ask this question. I was talking to a bunch of physicians last week, and these are primary care people and pediatricians, right? Mm-hmm. And one would think that you would actually, when you approach a kid, like you said, developmentally through their development phases, you would want to ask the parents, hey, do you know if your kid's breathing right?
Right. But they don't.
I mean, and they don't. And it's so weird because then you talk to them and we're like, when pediatricians send people to ENTs, it's the top 10% that sound like this all the time, right? Mm-hmm, mm-hmm, because it's either a significant, for lack of a better word, tonsil issue or an adenoid issue, and they're only 10% of the total. I mean, you can look at the statistics. If you look at kids going to pediatricians that complain about, I'll call it breathing and sleep, more sleep than breathing, 80% of them are actually all about, it's the developmental cycle and how they have to be retaught to do this stuff, right? Mm-hmm. And or just breathe through your nose. Mm-hmm. The 20% of them are kids that actually need intervention. Right? Mm-hmm. So what you're saying resonates because a majority of people don't even know. Heck, I didn't know, to be clear, that I was breathing through my mouth.
Right.
Dry mouth at night, waking up. It was all like, oh my God, okay, that's what it is. I just got to deal with it, right?
Right. It was like, that was the least of your concern. It was the if you're like me, it was the sinus infection. It was all the head pressure. Like I didn't think of it like mouth breathing was I was like, and I'm in that. That's my. You at least have an excuse from the engineering world. It's just my world, and I had no idea.
That's exactly. And by the way, the weird part about it is that through this exercise, even before I go to sleep, I have to use Sonu, and I have to make sure that there is still the psychological intentionality of closing my mouth when I'm breathing at night. And it's weird because somewhere, in some part of my childhood, I mean, I got braces. I got the full, they pulled out a bunch of teeth, more teeth than I should have been pulled out. And I mean, I barely survived, from a jaw and profile perspective, in terms of what's happened to me. But I can guarantee you that my palatal arch angles and my nasal cavity, I would say that there's been at least I would say 30% of my breathing problems are because of that, right?
Yeah.
So to your point, developmental phases and the symptoms associated with that are not recognized.
Yeah.
And I think
what did the pediatrician say?
So I asked them, they're like, oh well, he said that happens with most kids, and I'm like, wait, this isn't we were in a forum with a bunch of dentists and pediatricians, and I said, so what do you guys do with that? Well, the first thing that we asked them to do is make sure that. We tell the moms, could you guys make sure that you're showing them how to breathe through their nose? So I said, well, okay, that's great. You're doing that. And then they're like, and the other question that came back to me was, is it really that bad?
Yes, I believe it. I'm like,
wait.
It. Yes.
And the one thing, I think people generally are not used to hearing about ENTs and airways talking to the ENTs and airway people together, airway dentists talking to general physicians. That's not a combination that exists in a Venn diagram. We're going to do a big salon in Chicago at midwinter with ENTs and I think it's because care has been so spread apart that there's no continuity.
Completely. It's so siloed. You're right.
It's so siloed, and to your point, I think that's missed. So part of our goal with the app, we're actually going to this month. We'll have a free nasal airflow and airway report. Anybody who wants to download our app, you don't have to buy anything. Check your breathing by speaking into our app to show how much nasal flow we can quantify this stuff has been done for donkey's years before us. If you go to a speech language pathologist, or if you go to a traditional speech therapist, the first thing they'll ask you to do is speak, and they will record you with two mics, one going through your nose, one sitting in your mouth. You look like Darth Vader for the recording because they'll separate the two. But now we've got technology that can actually filter these two streams and words, that we can look at how much hair, if you say bringing, or if you say moon, I know the ums and the ns have to be pronounced with the air coming out of your nose. So the first part of this is education. You're already doing this, and I'm actually very, very, it's so cool that you have this being a mainstream thought process that you're trying to bring to general physicians, right? Very important.
Yeah, and that is, I was literally just on a call with an orthodontic colleague of mine within an hour of us hopping on, and she's going to speak to a group of pediatricians in a large group practice tomorrow evening, and she was asking me for some advice and going through some literature and helping her to prepare. And I said, one of the things, my goals for this year is to start to bridge that gap between the medical community. I speak all over the world now to a lot of orthodontists and dentists and even physicians and ENTs and sleep physicians. I haven't gone where I need to go to bridge that gap and connect to our pediatric medical colleagues.
I think Mike, that'll be amazing. You know why? Yeah. If you can bring the years of dental experience and treating kids' mouths and airways, if you can take a brick and really cement that wall out, you'll be helping at scale.
Yeah, because ultimately this has to come from every angle. The parents have to be educated. The dentists have to be educated. The ENTs, the sleep physicians, we leave out of that when we speak of this. Rarely do we say pediatrician, right? Rarely do we say primary care doc. We tend to focus on the specialists or on the people looking at the mouth, or even you said, the speech malfunctional therapist. So yes, reaching the medical community with this. What I find amazing, and I've had a bunch of sleep physicians on the show in recent episodes, they're the first ones to say they don't learn about sleep and airway either in their general education. They're not learning about this. Your average pediatrician, they have no idea. That's one of my, I don't know how familiar you are with the American Association of Orthodontists, what they call their white paper. One of the biggest objections I have is their answer to everything was, when we detect an issue, which they don't tell us how to even do it, but when we detect an airway issue, send it to the physician and let the physician tell us what to do. How many pediatricians have you met, just let's take the kids for a second, who have the first clue, and this is not a derogatory statement or remark on the ability of the pediatricians. It's not their job to tell the orthodontist or the dentist how to grow the face and develop the face. So take you for an example. You were young, clearly had a lot of dental crowding. That's why you had teeth pulled. You likely had breathing and airway issues and congestion back then, right?
Yes.
And so that's why you were growing with a small face, smaller jaw. And that constriction led to you having not enough room for your teeth. It's almost never big teeth. It's almost always small jaws.
Wow,
and
you're so right.
Right?
So
and it's often related to how you breathe. So there's tons of research on this, but the way you breathe can constrict the arches of the face. When you open the mouth, the buccinators of the cheeks stretch, they constrict in, the tongue drops, the palate gets narrow and high and vaulted. The roof of the mouth is the floor of the nose, and that all ties in. Then now, so that's one big strike against you that's starting to shape the way your face is growing. Now you continue to develop those allergies. You continue to breathe through your mouth. Now you're not using your nasal passageways enough, so you lose sinus volume, you lose patency, and now you have the inflammation from the allergens completely constricting it. And I've always been told, as a chronic sinus sufferer, sinus disease is an issue of drainage more than anything. It's an issue of drainage. The reason you and I would be on antibiotic all the time for our sinus infections isn't because we had weaker immune systems. It isn't because we just happen to be prone to these terrible infections, which there may be some truth to that. The main reason, which is why we go on steroids for a lot of this too, is because we couldn't drain. We didn't have the patency to drain. So what have you seen? Because I know when you said, and I appreciate you saying, like, the Sonu Band, which we'll talk more about it and the details of it in a second, doesn't treat sinus disease in that sense. It's not that we're treating disease, but what does it do to help mitigate the disease process?
Yeah, that's a great question. So I'll give you there's two modes of action, right?
Okay.
You said it correctly, drainage and patency. So, and Peter can give you the actual neurobiological basis for how it exactly modulates the autonomic pathways, but I'll give you the physics behind it. So I always like to show this. This is a beautiful representation of a sinus cavity.
Okay.
It's got, it's almost pyramidal, it's hexagonal.
Yep.
It's a nice little vase that I have on my desk.
Yep.
But if I blow through this, you hear a sound, right?
Yep.
When this is blocked, to your point, there's no drainage from the sinuses, whether they're here or whether they're behind your eyes. So the first thing that needs to happen is mechanically, we need to make sure there's enough energy here to unblock this cavity. So when we are vibrating the actual, what I call the apex of the sinonasal cavity, which is here,
Up on the forehead.
You're physically vibrating the sides of this sinus because sound travels. There's zero loss, bone conduction loss. Sound travels into your nasal cavity. So what it does is mechanically you're transferring energy to do what you just said, which is you are changing the aerodynamics within this cavity. So if you go to our website or if you go look at physics at MIT, they'll show you an experiment. They'll blow on a bottle, they'll cork it, and then they'll basically take a speaker and put it underneath it and resonate it at the sound that they heard, and they'll blow the cork out, right? The reason they do that is the physics of resonance. I mean, I'm sure you've heard of wine
shattering glass, right?
Yeah, exactly, same thing.
Yeah.
So
Yeah.
we're using
With your
sound
finger on
waves
top.
Exactly. We're using sound waves to shatter the little plug of mucus that's preventing you from draining. Number one. Okay. That's the physics and the engineering part of it. Now, in order to do that, Peter had my CTs. So he could go and say, this is the volume. We can't blow on my sinus, but we do know that my sinuses shape my voice. So he can detect my voice, but he can also look at a CT scan and look at how does this look and what is the volume, what is the size of this particular cavity. Therefore, if I vibrate this cavity at the right frequency, which is the resonant frequency of this cavity, then I can change the aerodynamics of the air within the cavity.
Okay.
Therefore, I push out whatever is blocking it. So in order to do that, he had a CT. But my big thing was, well, nobody's walking around with a CT scan of their head.
Right.
So
how do you get that information?
And so that was the first engineering thing that we did. And that's why I got really interested in this, because for me, I'm a data scientist. So I'm like, well, if I have your head, can I train a model? So when the pandemic shut everything down, we spent 1.5 years actually building the entire first AI database of many, many, many hundred CTs and people's faces. And we mapped all of the invariant facial characteristics, the eye orbits, your alar edges, your mouth, your tragus, your nasion. We basically trained AI and machine learning to be able to predict what your CT would look like based on your face.
Wow.
So we can get, and we published all this.
So that's when you get, that's the scan. When you get the app, that's what the scan is doing. Okay.
Exactly. And as a dentist and as a physician, you will appreciate one more thing. Once you know that anatomy, I bet you if I put you in front of 100 kids, you will actually single out people that have airway issues, because in your mind, you already know the types of faces.
For sure.
I guarantee you.
Yeah, I can't go anywhere and not see it.
Exactly.
I'll be at a restaurant, I'll see a kid or an adult, I'm like, they have an airway problem.
So we've taken that. We can never get to your quality, but we can give you and dentists the tools. You understand it because you've done it for so long. But we want to give every physician, pediatrician, internal medicine guy an airway report without going through a cone beam.
Yeah, okay, interesting.
When you have that data, then you as a physician and you as an educator can say, hey, most people have these types of characteristics. Mid-face, occlusal angle, you can see a high palate from 6 feet away, right?
Sure.
By the way, if I can give you numbers, then it's a really non-argumentative discussion. I read the 2019 orthodontics paper, and I was shocked because, we're coming from medicine, right? We're coming from ENT. and we're like, wait, some of this stuff is so, we're all data-driven. And forget all the people and personalities. At the end of the day, if you look at a cone beam and you understand an airway and you understand that the airway is bounded by dentofacial structures.
Thank you.
That's like that's like, it's not, I'm an engineer and I understand that.
Right.
Forget
Why are
being
we
a
debating?
medical
Yeah,
guy.
thank you.
There's no debate. There's no debate there, right?
Why are we arguing over this as orthodontists?
Yeah, so
That's a whole nother discussion, but thank you.
Yeah, and by the way, I'm not involved in that field, so I have no clue where that whole thing came up from, because I know Eric Phelps, I know Kevin Boyd and all, and it's so weird. I'm like, guys, we're arguing about like the sky is blue. I mean, there's no argument, right? So to your point, I think our goal is to enable you and the people who are actually bringing education into this field with data science. So when we calculate and we know all of these things, the airway volumes, the sinus volumes, the actual location of the pterygoid process and the sphenopalatine ganglion fossa volume, which is what we're modulating with sound, we are enabling parents, kids, patients, and doctors with data.
Yeah, it's so true.
Then there's like, okay, guys, here it is. And we have your voice, which is the most sensitive biomarker. I mean, I was going to ask you this. In all your years of practice, when you've expanded somebody who've done airway work, hasn't their voice changed?
Oh, there's completely. I mean, sometimes with us, they're going through puberty, but then some of the younger kids who are prepubertal, completely. I mean,
completely.
You'll hear the parents will say that. They say there's a difference in how they sound. I noticed it a lot working before I understood how to work with malfunctional therapists, because it was not a thing we learned in school for sure, and it wasn't anything I was doing through a large part of my career until I understood it more. I would have their speech teachers in school, which was kind of the most direct representation I could get. The parents would come in and say, his speech teacher said he's articulating so much better now. He is more intelligible. He is more understandable. The teachers aren't having as difficult of a time understanding him pronouncing his R's or his S's or his F's, the fricatives. Again, I'm embarrassed to say, I didn't know. I'm like, oh, I guess there's more room for the tongue, which does play in. But I didn't understand. I think it's what you said before. We're so siloed. I was looking at it as I'm in the mouth, right? Yes, I understand I'm moving the bones, the maxilla. But because we're not taught, just like we were saying, the pediatricians aren't taught the airway side of things, or the orthodontic side of things for that matter, we're not taught the airway side. Even in our 3 years of orthodontic residency, Paramesh, we didn't talk about airway. I went to 3 years after dental school, and we were told that, I mean, little to nothing. And we weren't told mouth breathing is an issue. We weren't told to really focus on how a patient breathes at all. This was pre-CBCTs. But even now in the profession, there's still a ton of resistance from my orthodontic colleagues to embracing cone beam technology. Why? I don't know. And the radiation used to be higher. You could make that argument. It's not anymore. Oftentimes with a low-dose scan, it's lower than with 2D imaging. So there's so many obstacles. It's so interesting to hear your perspective from the engineering world as an outsider to this sort of orthodontic dental world, to look at like, what are you doing? Yeah,
because it's like, when you show somebody data and physics, usually in our world where we come from in computer science and engineering, it's like, okay, guys, prove it to me. Here's a model, here's regression, here's results, right? And usually you're like, we argue a lot about algorithms and how good they are, but we've got we've got kind of quantifiable models. And in this instance, imaging is so key. I mean, the radiologist who helped us with all this is a Caltech grad. He runs one of the largest radiology practices in Santa Clara County, right? So he's Stanford affiliated, UCSC. So to me, all of this stuff that we're doing is super science-based. It's not like, I'm not like pulling out a woohoo from the air, right? It's so funny because, it's when we went to the FDA, we had to go do de novo. And by the way, they wanted every freaking piece of cadaver data that we have. And I say that because during the pandemic, we used to x-ray cadavers fresh as they came in, because after 2.5 weeks, all of the turbinates and all of the stuff that's preserved actually degrades in terms of volumes.
Right.
So I mean, think of the amount of work, and it's funny, I probably scrubbed into a dozen to 2 dozen surgeries of different sorts to actually look at the way rhinologists go in and actually how these structures look, and make sure that all of the imaging data that we're seeing, all of the imaging data that's registered, all of the patency data that we're going to do with the rhinolonometry is actually correlated, right? So because we can't, I mean, that's the one thing I think that you brought up, which is you got to you have to look at the data science piece of this. Otherwise, we're going to be talking about things that are subjective. And I think the airway is the first ever portal where you and your colleagues and all of us in the computer science space and the ENTs, there's actually a common ground that we can talk to and say, this is the data, right?
Yeah.
You at the end of the day, data, and you have clinical outcomes. And by the way, we're not talking about small statistical correlations. We're talking about massive statistical correlation.
Mm-hmm. Yeah. Yeah. It's very true that I think a lot of it's dogmatism, right? We're just so, we think if we don't learn it, it's not a thing. I mean, and honestly, and this is just kind of human nature, right? If you go to school for as many years as we did and pay as much money as we paid to become a premier specialist in a particular discipline, in this case, say orthodontics, but really anyone in dentistry who's even gone through dental school and then out into practice, human nature is, if it was the thing, I would have learned about it. Right. And I don't mean that a modification of a technique. We all understand that techniques change, technology changes. Where I think the big obstacle comes from is there's been a lot of literature, just to give you a little color on this, there's been a lot of literature in the orthodontic world trying to push back, saying that airway has no place in orthodontics, that we can have no impact on it, that all the data, because they ask for randomized controlled trials, which, as we know, because of equipoise and other ethical issues, it's really hard to run a randomized controlled trial on children to see if one therapy works over another. It's not like you could do something like the Sonu Band or even a pharmacologic agent where you could say, take this pill or don't take this pill, and you could monitor it. It's really hard to deprive a kid who has a narrow maxilla from getting expansion because even if you know that, even if you're debating whether it helps their airway, you know there's other benefits to that expansion to normalize that anatomy. So it's really, really tricky. So people are like, well, there's no randomized controlled trial. Well, anyway, and I talk about this all the time, and I'm sure you well know this, but evidence basis is not only randomized controlled trials. As you said, the data are one part of it. Randomized controlled trials are the highest level of that sort of scientific triad, a part of the triad as Sackett developed it. But there's the clinical component, and then there's the patient preferences and values. And so we can look at all these things together. And where I get so frustrated with my dental and especially orthodontic colleagues is they just tend to hyper focus on wanting those randomized controlled trials. Yet we have so many patients that benefit from airway focused care, right? And again, I say all the time, we're not, as orthodontists, what we do, we're not treating the airway. Just like you're not treating the airway. This is a multifactorial disease. Airway disease.
That's exactly right.
Right. There's no one magic pill, silver bullet that's going to cure it. Right. So why don't we look and say, if it's multifactorial, the solution has to be multifaceted and often multidisciplinary. What you're doing, and we'll talk more about the technology and how you develop that in a second here. If we can take people and take one complication out of it, which is the inability to drain and the decrease in patency and the increased turbinate inflammation, and address that along with, and maybe some people, and correct me if I'm wrong, still might need a surgical procedure to clear obstructions.
100%.
Right?
100%.
Right? So it's not like any of us are sitting here saying, only do expansion, only do acoustic resonance, only do surgery, only 100%. Do steroids, right? So comment on that, if you would, a little bit, why we tend to be so ingrained in one or two particular approaches and the need to kind of be more macro and look at this from a multidisciplinary standpoint.
Yeah, I think you touched on it, perfectly, which is, if we can collapse the walls between these different specialties just enough to let the knowledge permeate across them, and to your point, nothing is a panacea, right? I mean, they're talking about RCTs. We've done multiple of them. That's how we got FDA clearance, etc. But it's really interesting. The big things that we're doing going forward are patients, we cross over patients even in an RCT. They're their own control because everything is so individualized, right? Number one. Number two, the multifactorial piece is the very critical piece. And to me, this is the part I resonate with you, and I'm also a little confused about, which is, why is there's no downside to treating one factor? If there is a no downside way to treat one factor, why not do it?
Right.
And I'll tell you why. I think that the biggest thing here is that, in my mind, there's been a lack of systematization of how this happens. And if you ask me, because I'm new to this whole airway field, and I'm not, again, you guys have direct patient experience. I am a patient, and if I put myself in my head into every patient's head, the one thing that we've all been used to in the last 5 years, and I don't care if you're an orthodontist or a dentist or a general practitioner or an ENT, People are armed with knowledge these days. When they come to see,
Yes.
the number of people that they're like, oh, can you send me all my airway stuff? I want to get, we've got 80% of people want to request longer history of voice recordings. So we're going to just give that to them and say, here's how you sound. Because people want to take control of at least the factors that they believe are symptomatic.
Yes.
And I think that's the one thing that you said, which is in the multifactorial loop that we're dealing with, if there's a way to arm people with, here's some therapy, here's some data, then you're empowering. I mean, I'm a big believer in empowering people, because at the end of the day, I don't have a doctor that sees me 24/7 for everything. Doesn't work. It doesn't happen.
Right.
It doesn't work
Yep.
that way, right? So I think you guys, it's funny. I would say that the dentists see people more often than a doctor does.
Yeah,
Because of
completely.
all of the sleep stuff is diagnosed by them. 40% of it is diagnosed by dentists, right?
Yeah.
So I think I think what I see in the future, and to your point, is our goal is to become the trusted repository and the purveyor of data to the people that are using devices.
Yep. Yeah.
And they're your data, it's not mine, right? Meaning we are showing you on standard scales how to measure this. I think that'll do two things, to your point. One, it will emphasize that multifactorial treatment is indeed possible with no downside and a data vector to move it in whatever dimension you want. I'll give you an example. We had a bunch of people say, hey, we want to insert Sonu. We want to do it before we do any aligned treatment. I said, why? Well, we want to see what happens, and we want to measure their airway so that we can be even more precise about what we're going to do with these people.
I was literally going to ask you that, Paramesh. I was going to say, because one of the things we're struggling with in our field right now, and I interviewed Ellen Stothard, she's amazing. She works with Dave McCarty at Rebus, who's been on the show. He's a sleep physician. And Ellen's a researcher, brilliant. And we're talking with Ellen about how we analyze this data, right? How do we analyze the data to show longitudinally these changes that we're receiving and obtaining in our patients? And yes, we can do pediatric sleep questionnaires, and we can do intake type questionnaires in the beginning and the end. That certainly is good. Yes, we can look at CBCT images and radiographs and clinical photos before and after and show that. It would be nice to have something quantifiable, something objective that we could just say, hey, look, I am seeing over 1,000 patients. Pre-treatment, they're here. And when I do this type of treatment, post-treatment, they're here. And Ellen said, as a brilliant PhD researcher, she said from a statistical standpoint, she said, that's valid data. She's like, that is completely valid data. So how could what you're doing with the face analytics, voice analytics, resonance studies tie into that potentially?
So great question. I'll give you an example. We just published this and I'll send it to you. It just got accepted in January. We published the longest ever usage study for people with allergies. 2,375 people followed with Sonu bands over a year.
Okay.
And she's right, because we went through multiple review with the largest impact journal in the world for ENT, IFAR. They're like the top. It took us 6 months. They went and asked us to analyze the data anyways to tomorrow, because they're as skeptical as we are, right? When you look at this stuff. So, but the one thing that we can actually look at is we can tell you now what the depth to height ratio of a nose and the usage is and how they're correlated. So we can look at the face shape and correlate that to usage for rhinitis before and after with nasal scores.
Wow.
So you're onto something. And how are we going to do this? We are actually embarking this year on a full remote therapeutic monitoring program that actually is even reimbursable if it's done with a physical therapist or a speech language therapist or a dentist that's empaneled with insurance.
Wow.
These codes do not require a medical license to be billed. So we want to take therapeutic monitoring and get everybody on it. And it's, I mean, for the most part, the wearing of the band constitutes as a therapeutic event because it's FDA cleared pharma equivalence. Never happened in the history of this. Okay. So now you have the ability to take their voice before and after. And guess what? Scan their face. So you will get over a year. And by the way, you had a really great point. How do you account for puberty? Well, there's curves that have been established for years on BMI and facial shape and facial fat on what puberty does. Normalize out all the pubescent data, and see what you get out. I don't know what the answer will be, but we'll have the data.
Yeah, that's so great that you're doing that, because that's what we need. And you also made another great point about people being educated in that data, and the public, the patient wanting the data. And
exactly.
I just spoke to another orthodontic colleague, a friend of mine recently, and he said, the orthodontic marketplace, I will preface this actually by saying, just to give you a little background into it, I have been saying for years to my orthodontic colleagues, the orthodontist better wake up on this whole relationship between airway and orthodontics. And I'm not a fan of the airway orthodontist term. I think as an orthodontist, you're an orthodontist and dentofacial orthopedist. Airway is part of that. Period. Exactly. Hard stop. We don't need a separate airway orthodontist subspecialty. We are that's our domain. So anyway, this colleague and I were talking about it, and he said, yeah, Mike, he's like, honestly, I'm seeing a ton of new grads come out. Like, it was a few years ago, even post-COVID, it was hard to find docs in a lot of different demographics in this country for a senior doc to find a junior orthodontist. He's like, I've got my pick now, and I'm not even advertising for it. I said, what's going on? He said, what's starting to happen is, because of plastic, aligners, all of that, and being done outside the orthodontic office, patients are seeking care elsewhere, and there are more orthodontists graduating. So you're getting a saturation of the market of orthodontists. And I said to him, this is what I've been saying to our orthodontic colleagues is going to happen. That's why we need to be involved in overall broader perspective patient care, not just these robotic tooth straighteners who sit there and try to line the teeth up best and argue about who's got better mechanics to line the teeth up. I love straightening teeth. I pride myself in being very good at it. That being said, if we don't wake up as a profession in orthodontics and understand what we can be, I look at it, and I don't know, I'd love to hear your perspective. I feel like orthodontists can really, and a lot of non-orthodontists listen to the show too, so I'm certainly not trying to play to my orthodontic colleagues on this, but I feel like we have a unique position to really take this by the reins and run with it, and say, look, this is our wheelhouse here. We're not doing that. Again, that we don't have to get in more detail on that. But what do you feel could be the use of some of this technology in the average office? Just even say dental office. So, okay, we hear this, we see this technology. Like, how does that play into our lives?
That's a great question, right? So I think the first thing we need to do is bring education to everybody. So if I can, I'll give you we're putting together a full platform for screen, treat, and monitor. And the treat is not just Sonu. It could be whatever you guys want as dentists, orthodontists, practitioners. But the one thing that we want to do is screen and scan before they come and see you. Imagine you getting a report, no cone beam I actually show you, I can send you screenshots of what we have, and you can go play with the Airway app. You have a full skeletal report of all of the orthofacial bony structures, all of the clearances to within 90% of a cone beam, and you have their voice over 2 weeks that you can look at their So we're looking at spectrograms. This is not like, this is stuff that audiologists have established, stingers have established, and laryngologists have established for 50 years. You say, here's how I sound through this week. Here's how my trebles sound. Here's how my bass sounds. And by the way, here's all my facial bones. Here's all my maxilla. Here's my volumes. You have the data. So if you, as a physician and an orthodontist and a general dentist, has a report that you get before the patient even comes to see you, then you have the first element of a data-based treatment algorithm. Yep. That takes away all of the, I don't know what to do. I don't know whether this is subjective. One of the dentists said, we've gotten accused, one of the folks that we're working with said, we're getting accused of over-treating people because we are, this is all heuristic. I'm like, well, that's like going to an ENT surgeon and saying you put a balloon when you didn't need to. They don't ever ask you that, right? Right. So I think the point is we're going to get appropriate anatomically correct data to you with a biomarker that's real time that you can use as I'll call it stake in the sand to say, this is it. This is where you are today. And then that's your baseline from which you can operate. There's so much literature in the sleep and ENT world that we can bring to bear with data science to show you how face structure and real-time anatomical features matter there. So number one, educate with data and make that data easy. At scale, Eric Phelps in the Bay Area is working with us. He wants to light up all the elementary schools.
Mm-hmm. That's what I'm thinking. Get this in the hands of nurses.
Yeah. Download the app for free. And by the way, it's your account, your kid's account. You can see all of this stuff. But if you want to go decode that with a professional, you got to go to a dentist.
Mm-hmm. Right.
Because we at Sound Health don't treat people. We give you data. That's my stance is I can make any judgment I want, but I'm not as qualified as a professional. Mm-hmm. And I think you're right. If the orthodontists take up the challenge, they already have if they can actually, they have the positional authority to take up that challenge.
Yep. And
say, here's the data. Here's the here's pre-CBCT data, guys. I really think you need to do A, B, C, D, E, F, G based on my experience. Then it's a very easy transition step to a treatment plan.
Yep. And then you can show results, right?
Then the second piece is...
It's quantifiable.
Yeah, and we're going to publish a paper on this soon. We have 2 studies, a clear aligner study and a MARPI study.
Okay.
Where every week we're doing a facial scan, we're doing a voice scan, and we're doing a voice scan supine and erect. So you can actually look at what the actual flows are between these two. And by the way, everything is for you to hear. It's not me, the doctor, making it up. Here, let's see how you sounded here. Let's look at your spectra. Let's see how you sounded in week 4. And by the way, let's also track your alar edges. Are they moving? So you'll have a multi-dimensional way to track people through the expansion process. And then once you're done and you hand them off to a Mayo, every month you get a pair of scans. Because at the end, you want to finish that arc over the year and say, hey, I just didn't make you look cool and beautiful smile, but I made sure that you breathe right. And here's all your data. That's our goal, right? So the whole platform should be at scale. We want people to be downloading these apps and for free. We don't want anything on the front end. We're doing the work. At least that's our little contribution to this big field, right? And if you use Sonu, great. If the doctor says, no, you don't need Sonu, fine. That's the doctor's judgment. We highly recommend it because it's a no pharma option to keep the airway open as you go through expansion. But then you can monitor our stuff and you can actually bill insurance for it now.
Wow.
So I think
great.
there's that access of pre-scan and screen. During the treatment, you as a doctor or you as a profession have all the data, and then through the arc of the first 3 months of whatever dental treatment or aligner treatment, MARPI, and then after that, you have this whole arc of 6 months. Imagine that level of data. A patient, if I'm a patient, I would love it. If I'm going to get my kid and spend $8,000 on an aligner or on a MARPI, I want that data.
Right.
And I don't care if you're sitting in Stanford or you're sitting in Tennessee. People want that data, right?
Yeah. No, I agree. And then they can cross-reference it. I'm not sure if you're working on this as well with the symptoms, right?
Exactly, right? Because then you can say, oh, I sounded this way, and exactly right. So there's no direct access there, but you guys, you're the professionals.
Right.
You have the unique ability to give them advice there. It's huge.
Right. We can dial in. It's kind of like diagnostics, essentially. We can improve our diagnostic capabilities, right, to be able to hone in and say when patients present. This is getting further down the road, but where my mind's going with this is we can then, which is where I really see AI playing a role in all that we do. It's in that honing in on the precision of diagnostics to say, okay, when a patient presents with this type of scan data, this type of voice data, this type of clinical presentation, what their malocclusion is, what their facial form is, what they're in, say you do CBCT as well, whatever your diagnostics are clinically, this is what their TMJ issues may be. Maybe they have a TMD or not, right? You put all that together and then you can custom build a treatment plan. And we get away of this whole argument of expansion for everybody, or let's expand everyone with an airway problem because it cures it. And this argument, which I don't even understand. You said it so beautifully before. It's not about expanding being this, again, magic bullet that cures everything. If they're narrow, they can benefit from expansion. But the problem now is, Paramesh, we don't really know outside of what the patient kind of reports whether that expansion really did anything quantifiable for the airway. We can measure volumes, right? We can do rhinomanometry. We can even do volumetric analyses on CBCT or CT images. It's really hard, though, to dial it in and say, okay, when I do this on this type of patient, I get this result. And I hear from docs and colleagues I coach and speak with and people on this show all the time. And they say, Mike, it's frustrating because sometimes I expand or I do whatever it might be, whether it's early expansion in kids or MARPI in adults, and it works and they're great. And then in others, it just doesn't do it. And it doesn't seem to help. And I think where you're getting is, let's figure out ahead of time who that's going to help, right? So we can tell that patient, hey, look, based on how you were presenting to me, you've got a really good chance that us just dental alveolar tipping and making a little more room in the mouth for the tongue or whatever it might be is really going to help you. You don't need to go through this very invasive process. I mean, that really is where ideally we want to be, right? That we can dial it into the patient.
I think you hit the nail on the head in that it's got, I call it the degree of treatment, right?
Mm-hmm.
And I think with the data that you have, you'll be able to very fine grain. I mean, think about it. 8 years ago, we couldn't even tell what the anatomy was before, and we didn't know what the voice was. Now we can do it real time, right?
Right.
So now you have the ability you can even do the customized treatment plans can be week to week.
Right.
I mean,
right.
It's really interesting, right? You don't need to have the MARPI for 3 turns over a week. Maybe just 1 turn and you're done.
Right.
I don't know.
That's such a good point because we don't know, right? But we don't know now. What your point being, the exact parameters aren't as relevant as as the bigger picture of what you're saying is we are guessing.
Exactly. So I think we can arm you with the data, and we can collect data at scale and let the patient be in that journey with you. It's a big deal.
Yeah, no, I completely agree. So this is really, really exciting and where you're going with it. So on my experience with it, save that for the end here. It's been great. It's been great.
Oh, good. Thank you.
I have noticed a difference. I haven't been able to wane completely off of my nasal steroids yet. I still do my irrigation. But I have noticed at night, it's much easier for me to breathe through my nose within the first couple nights, Paramesh, of using it. And I'm using it twice a day for 15 minutes. And I noticed within a couple nights, I'm going, wait a minute. Holy cow.
Yeah, for me, it's a big deal. In fact, you're right. To me, that's my Achilles heel. If I don't use it at night, I can skip the morning. Like I'll put it on for 5 minutes, I'll be running. I'll be in my car. And then in the night, if I don't do it, I can feel the difference. Big time. Right?
Yeah.
Big time.
No, so. It really is. I used to, here's the best example. I never could sleep on my right side because my bad side's my right side. And anybody who's a sinus sufferer knows, right?
My left.
Anybody like us knows you got a side and you always have to favor that side. And so I always have to sleep on my left. I can't sleep on my right side or I can't breathe out of the right side of my nose. And I would wake up periodically through the night and I'm not a snorer, but I definitely would just have, my mouth would be open a little bit and I'd wake up with my head on the left side and I would feel pressure on the right side pre-Sonu. And then within a few days to a week of using it, no joke, I woke up, I was on my right side. And my wife said to me, she's like, I don't think you've ever slept on your right side since I've known you. And I mean, like I literally, because I couldn't breathe. I would basically occlude the one side and it was uncomfortable. So I'd have to rotate. Yep. So so just as a little, N of one
so
here
cool.
with me with that. I never told you that, but yeah.
That's so cool to hear.
Yeah.
I'll leave you with one more thing. So one more episode that I just heard about from a pediatrician. He's a very famous pediatrician in the Bay Area. His nephew, so he ran our pediatric study at Stanford. And he goes, hey, my nephew has been, I gave him the band. I'm like, hey, try this out. His nephew is 24. Okay. And he goes, he's had severe problems, so much so that he's lost his sense, or he thought he lost his sense of smell. Mm-hmm. And he's had severe nasal issues. He's on antibiotics. So he used Sonu for 2 weeks. And he wrote an email out. It's very cool. I'm going to frame this. He said, first time in my life, my early adult life, I'm smelling soap.
Really?
Yeah.
Wow.
So it's really interesting. And by the way, you recognize that all those nerves are up here, right? The nasal nerves, that the smell is all, the olfactory sensation is all in the bulb up here. So if the airflow, so there's very little air that's actually going up there, extremely small. Yep. Most of the airflow is in the lower part of the nose, right? Mm-hmm. So imagine the amount of occlusion he must have had that he didn't even get that level of air up. You need, it's a diffusion process up, right?
Yep.
So it's very interesting to hear that. And for me, I'm like, wow, that's like, so he goes, now I use it every day because I'm starting to smell things again that are, and he said, I used to get, my spectrum was like black and white. I used to eat arrabbiata sauce, and he's an Italian, and he goes, I could sense the fire, but I couldn't sense the tartness.
Yes.
So he goes, I'm like, I was like, whoa, that's so cool.
Right? Yeah. Yeah, no, it is. And how do you, and I have actually one more thing I want to tell you too about a physician and commented on the Sonu that I haven't told you about yet. But how long after, is there a refractory period? Is there a period where if you stop using it, it will fade out? What have you seen in your research to see?
That's a great question. So it's funny. I mean, I've got engagement statistics over 2 years. Mm-hmm. We have over 12,000 people on it, and almost 70%, 65 to 70% of people use it once or twice a month in that. Okay.
Oh, wow. Okay.
So there's so if you look at the statistics, one statistic's twice a month is almost a 65 to 70%. However, get a load of this. We see two big statistical towers. People are using it 3 to 4 days a week, mm-hmm. and then people are using it 1 to 2 days a month.
Yep.
So it's interesting, and it's almost like it's a Golden Gate Bridge. You see two big statistical towers, right?
Yep.
So I do believe, and by the way, almost 40% of the people are using it 3 to 5 times a week.
Okay. Can you overuse
the rest
it?
Of them. Say again, sorry?
Can you overuse it?
No. So there's two things that the FDA did, good or bad. I don't know whether it's that. They've kind of cut the battery out, meaning we can't, because it's on your forehead, it's a tiny battery, right? Mm-hmm. So some people are using it twice or 3 times a day who are very chronically congested, especially in Texas. And we can actually see the locations of where they are.
Oh, that's funny.
Right?
That's funny,
it's very interesting, right?
Yep.
But no, you can't, because at the end of the day, there's two major safety considerations. One is, what is the maximum amount of audio amplitude you can put through bones over time?
Okay.
And by the way, the reason I say this is the FDA just squashed us for the first 6 months with safety data. They really pushed us. And the only reason we were able, the WHO, which is the World Health Organization, has I'm talking about regular headphone usage for 8 hours, and bone conduction headphone usage for 4 to 5 hours every day. Okay. That's why you have 40 million people in the country using bone conduction headsets today, running and swimming and hearing aid, right? So there's really no downside. However, we haven't studied what I call meaning we've not studied the extreme dose response. We don't have that today.
Okay. Yep.
But I will tell you that we have studied longitudinal responses, and for people who consistently use it, you can start to see the effect. The nasal congestion keeps continuing to go down, and then it plateaus off at what's called a normal baseline. Right? If they stop, you can start to see it creep back up. It doesn't come suddenly. It's more like over weeks.
That's
if I don't use my stuff for I can go, let's say I go to Boston or Chicago and I don't use Sonu for 2 days. I'll feel it, but it won't get in the way of it won't get in the way of my functionality, right? But if I don't use it for a week, I'm toast.
And so there's some individual variability there, it sounds like, too, based on
and it's because it's an autonomic effect, because we are modulating the sphenopalatine system, right?
Yep.
So that's the reason. But amazing, Mike. Awesome. Yeah. I'm going to run to my next meeting, but thank you so much for doing this. Amazing.
Yeah, absolutely. And how can people reach you and find you?
P Gopi, PGOPIP as in Peter on both, at soundhealth.life. Email me. Happy to talk, and very happy to converse on this very important and very vital topic.
No, it's been great. I really appreciate you coming on, and looking forward to having Bryant and Peter come on.
Yeah, and I'm looking forward to that. Looking forward to that, so that you can synthesize all this cool stuff.
Yeah, I'll kind of do a science engineering show here, and then a science data show there. So
absolutely.
Paramesh Gopi, so great, man. Thanks so much for all you're doing. It's been an absolute pleasure.
Thank you, sir. Appreciate it. Okay, bye-bye.
Bye. Welcome to Doc Podcast, Peter and Bryant.
Good to be here.
Thank you so much for doing this. I know how busy you both are, and had Paramesh on, your co-founder and colleague as well. And so his episode is kind of going to blend into yours. That way we can paint the bigger macro picture of the product and the design and what you all are working towards and what you built in the first part and the engineering side. And now we can get a little more granular, dig into the details of the science and the data here, and help the audience understand a little more about what you all are doing with this product, and really beyond that in some of the innovative work that you both are doing. So to start the conversation off, I guess if you could just maybe we'll start with you, Peter, and then Bryant, how you, from your end and what you were doing, developed this concept and how it started to come together, that you developed this concept of resonance and diagnostics, and really where that kicked off.
Sure. So I am a surgeon. I'm trained as a ear, nose, and throat surgeon. So during my residency, I had heard just indirectly from one of my attending physicians that for treating sinus problems, humming could be helpful. And it was just a very incidental hallway conversation. And of course, there's nothing about what we were learning in that moment as far as, how to treat sinus problems, how to do surgery on the sinuses. It was just this comment that it just kind of stuck with me. And it was something that I wanted to revisit because it just seemed like a concept that I needed to understand better. So that was in the 90s when I was a resident. And it took about 20 years to sort of incubate this idea. And where I met Bryant when I first came to Stanford, and we were looking in ways that we could innovate the ENT space. And then Paramesh was my patient, and he was all about humming because he practices chanting and humming. And we got together, the three of us, to figure out maybe there's a product that uses vibration to treat nasal and sinus problems. That was the genesis of it. And we got a product, and here we are.
Wow. Yeah, I think the biggest thing, Paramesh, is, Peter and I were just really like playing with this idea. We even went and bought little buzzers, like little vibrating motors that they put in cell phones. We played with this. And, the biggest question was, how do you choose the frequency? So this is where resonance comes in. So what frequency do you choose? You kind of naturally hum at the resonant frequency of your head and your sinuses. So you could either choose the frequency based on measuring it, like putting in a vibration of different frequencies and seeing which one's most resonant. But Paramesh had this great idea. Hey, we've all got this 3D scanner in our pockets, right? We've got this high resolution, 10 years ago, right? We wouldn't have had this, right? When iPhones came out, we didn't have the Face ID. So Face ID really enables a 3D scan of your face and let us build a model of your external anatomy and connect it to internal anatomy based on all these CT scans in the study we did. So we were able to build a model that translates that Face ID data into internal estimation of anatomy into a resonant frequency. And the resonance is key because, before I went to medicine, so I practiced primary care where, we see most of the people with congestion and airway issues. I was also an engineer before I went to medicine. And resonance is really powerful. It's the frequency at which the transmission of energy is like the most efficient. Because you don't want to be having to do a treatment for 5 hours twice a day, right? You want to do it as fast as possible. So that was another reason we chose resonance. So that way it's really optimizing the treatment time. And it's, much more amenable for patient use because we all know, if the patient doesn't want to do it, doesn't matter how good it is.
Right.
If it's not comfortable, if it's not, good for patient adherence, they're not going to do it. So we're really designed all aspects of this to be optimal for patient experience.
No, that's really cool and innovative. And I love how ideas like that start. Like you're saying, Peter, here you were in the 90s as a resident and you just, this stays with you. And I think so often, so many of those little things along our paths, we don't know how they're going to blossom one day, and some never do. But the fact that you retain that and then working together and bringing in such amazing minds like with Bryant and Paramesh, and then now you have this product, which I didn't even tell you guys this, but here's mine. So I am a major sinus sufferer. I had significant polyposis, allergy-induced, and rhinosinusitis, chronic, and had a functional endoscopic sinus surgery in 2006 with a partial turbinectomy of my inferior turbinate, and then back then was a little more aggressive than a lot of what's being done now. And then a few years later, the disease was returning, and I had a balloon sinusplasty of my frontal sinuses as well. And really trying to open me up and get patency and get drainage. And we'll kind of come back to that part of how this device ties into that and helping with that. So I have had to be on essentially nasal irrigation with budesonide. That was my savior. And my ENT back, who interestingly, part of how I developed a passion getting at airway and into airway-focused orthodontia in my practice was really through a lot of my experiences with the otolaryngologist personally, and then on the cleft craniofacial team at a hospital working with ENT, and it all just kind of came together. And he would always say to me, it's about patency and drainage. it's about patency and drainage. It's about getting enough patency. And so I had more head CTs than I'd like to even think about or count in those years, because it was really pre-CBCT. And I would just have obstruction. I couldn't drain. And so sometimes they'd have to put me on prednisone or on a steroid taper just to get in. A lot of times my ENT would say to me, Ramez Awad, he'd say, honestly, he's like, I don't even think I'm gonna put you on antibiotic. We just have to decrease the inflammation in there. So how does a product like Sonu tie into all of that for people? And let's just take it the spectrum. Everybody who just maybe gets a little bit of pressure and has some congestion, chronic allergic rhinitis, or even acute in that sense, to somebody who is really a sinus sufferer and is really suffering from disease. And whoever wants to go first on that can.
Yeah, maybe I'll start just because in the flow of clinical referrals, you start with your primary care doctor and then you go to ENT. So, patients who come to me, it used to be, they come to me for prescriptions, right? Hey, what do I do about this? Now, most of the drugs are OTC, right? Mm-hmm. You've got your Flonase, all your nasal steroids, even nasal antihistamines over the counter. People try, Claritin, Allegra, Zyrtec, again, over the counter. So they've tried pills, they've tried, nasal sprays. They may have done sinus, irrigation, sinus rinse, or neti pot. Mm-hmm. So it's changed over the past 20 years where they used to come to me for a prescription. And some people now still do, but some of them come and say, hey, doc, I've tried everything. So for the people who haven't tried everything, we try to use different medications. But, a couple of problems with that. No treatment is 100% efficacious, right? Nothing works for everybody. And also, most people don't want to be on medications all the time. So that was part of what drove us to say, hey, let's make a medication-free treatment for nasal congestion. For those tough cases, you'd be one of those tough cases. Paramesh was one of those tough cases. Then I refer them over to Peter. So when Peter gets them, these are the toughest of the tough, right?
Mm-hmm. Yeah, and I think what your experience is, Dr. Mike, is not uncommon at all. There's uncontrolled inflammation, despite compliance and extensive medication. That's just what we see. And that's actually what Paramesh came to me with. He actually had a negative CT scan, actually, but he was done with medications. And so, that's, I think, where this type of treatment can fit in. We don't have an FDA indication for sinusitis, but we're very interested in the potential applications. And our FDA indication is for nasal congestion. But irrespective of what your specific diagnosis is, I think one of the things that over the years we've learned in terms of the pathophysiology of nasal and sinus problems is that there is a neurogenic underpinning of all of these diseases. And so whether it's allergic rhinitis, non-allergic rhinitis, sinusitis, the things that you feel in terms of hypersecretion, edema, swelling in the nose, all of these things have a neurogenic basis. And so autonomic nerve system has really become much more interesting to think about as really the underlying mechanism for all of these disease processes. And we didn't really understand how vibration actually could work. And we still are learning about it, but we've learned a lot since we started with the product. And we do know that vibration is helpful in terms of sonication of mucus. So if you look at cystic fibrosis patients where mucus is the problem, we know that vibration therapies to the chest actually have the greatest efficacy compared to percussion, just patting on the chest or other ways of moving mucus. So vibration moves mucus. Vibration also stimulates nitric oxide production. So for nasal sinus health, we know that exhaled nitric oxide increases with vibration to the nasal cavity and sinuses. The third piece is the part that we've really learned the most about, which is going back to the nerves, and autonomic dysregulation really seems to be the thing that is the target of Sonu. So neuromodulation, which is, we didn't realize it, but, neuromodulation has become such a buzzword these days with all types of therapies, but that's how we believe Sonu works. And specifically neuromodulation of autonomic nerves and neuromodulation of the sphenopalatine ganglion which is like the nerve center for the head and neck. That's, I think, where Sonu is working. But it's probably multiple mechanisms that lead the benefits that our patients experience.
He actually beat me to it on the question, because I was going to be asking, how do you really quantify, or can you quantify how this works? And so the neurogenic component, having the neuromodulatory piece of this, and then is it ciliary motility that we think with the vibration? Is that what is happening on a, sort of a mechanical level?
Yeah, I think so. I think the neuromodulation in particular has many actions, but in particular, we know it causes vasoconstriction. When you have edema in your nose, part of that's because there's so much blood flow because of the inflammation or other reasons. And that's how most decongestants work, right? They cause vasoconstriction. I was sort of, I know Paramesh says he's patient 1 or patient 0, but in terms of endoscopy, Peter looked at my nose, and I was one of the first people that we actually did an endoscopy, nasal endoscopy, wearing the device. And my right nostril was very obstructed. Like, I just felt very congested that morning. And I put it on, and then he could see contact with the turbinate and the wall, the septal wall. And you could see it shrink. I mean, he couldn't leave the probe up there because, you can't. He didn't want to spray to interfere with anything. So he took a look 3 minutes later, and it already opened up, and I felt better. So I think part of this is that it has an acute benefit, right? You feel better very quickly, and there's a long-term benefit. Our randomized control trial showed that actually the second week was better than the first week. So there was an acute benefit within minutes and a long-term benefit within, a couple of weeks. So that was really satisfying to see. And that, shows there were probably multifactorial. There are multiple reasons, as Peter said, on why this works.
Yeah. And it's one thing I find interesting too, because things like Afrin, like I said, decongestants, the tachyphylaxis, the rebound effect that most people I think know of. And as I mentioned to you guys before we started, there are a lot of laypersons that listen to the show as well. And I think most everybody, even not in the professions, has some sort of awareness that you're not supposed to use those types of sprays indefinitely. The steroid sprays obviously have a different mechanism. That being said, it still is, and there's some systemic absorption. Correct me if I'm wrong on that, but it's small, but it's there, and it's something I'm concerned about as a patient who's been using nasal topical steroids for let's see now, when I was in dental school, and that would have been 28 years ago. So I've been using them for a while, and that's something obviously you get a little concerned about as you start getting older. So when you have a device such as this and you're using resonance, is it that you are building up, so you said the acute effect and then sort of the more long-term effect, the duration. What is the duration that you find in most patients, and what did your data reveal that you find it takes to get meaningful change, a noticeable change and symptom relief? And then at what point, or is there a point where that plateaus? And then do you see if they decrease use, can they maintain it with sort of a less frequent use, or do they have to stay at that sweet spot, and kind of how do they find that sweet spot, if there is one?
Maybe I'll start and then hang it off to Peter. I'll just comment. Before we did our randomized control trial, we did an acute study. So we did a pre and post study. We had people come in with acute congestion. We had them wear the band for 10, and we assess them at baseline. We had them wear the band for 10 minutes and then another 10 minutes. So 20 minutes total. And we saw acute benefit in that study that led us to believe that, hey, there's something here that may be beneficial in the long term. And I'll hand it over to Peter in terms of long-term effects.
So we have, beyond the FDA trials that we did, and the FDA was interested in longer term data. So we had that 2-week study where we learned that week 2 is better than week 1. Beyond that, we have real world data. And the real world data is the most interesting because this is just anonymously who uses the Sonu, well beyond the period of study. And what we see is that, first of all, there is good adherence to it. So patients like it. They find it valuable. They want to continue to use it. But we also knew that when we designed our clinical trial, is somebody going to use it 15 minutes twice a day? And is that the only way that it can be used? Absolutely not. Okay. We have to talk about that in public because that's the labeling of it. But what we see in real world studies is that some people drop down to twice a week. They might not do it twice a day. You might use it a little bit more frequently. Probably it's related to exposures also. So, you have a wildfire in your area, you're going to use it more. So what we're seeing is consistent use at generally lower frequencies, but the stickiness of it means that we think that it's bringing something therapeutic to patients. So I think that everybody probably lands at a different place in terms of the need to use it. We can always go back to Paramesh because he is a patient and a really loyal user, but he will say, if he's traveling and maybe forgets to have the device, by day 4 or 5, he really knows that he's got to catch up and get back on track. But it's definitely not the rebound type effects that we're seeing, like you mentioned with Afrin.
Okay, interesting. And on the neuromodulatory impact, have you done anything or seen anything where it has an autonomic effect beyond maybe just localized in the nasal cavity region and in the paranasal sinuses and in those tissues? I mean, is it getting at the vagal nerve in some way? Are you seeing? Do you have any data on that where it's starting to maybe have even more of an impact than you anticipated when you started down this path? And maybe whichever area of expertise would be more appropriate, just jump in.
Well, I'm not a vagal nerve expert, but I will say the feedback that we get about what people experience with this is well beyond just the nasal congestion component. A lot of people say, it's very relaxing. It helps me sleep. I've had some patients say that their TMJs relax. So there's something about myofascial tone that seems to be, in some patients, related to this. And what we do know, though, is that there are nerve inputs that are... there are vagal branches, actually. The great auricular nerve carries vagal inputs. And when you're wearing the headband, you're vibrating those areas. And actually, some of our allergists have reached out to us to say, you got to speak to the GI docs because we think that irritable bowel syndrome might be treatable with something like this. These are things that are just very intriguing that we need to look into, but we hear enough about this relaxing effect that we do think that the vagal nerve somehow is related. And with regard to the sphenopalatine ganglion, I mentioned that earlier. I really think that that's relevant because so the sphenopalatine ganglion, just for the listeners, and it's a nerve center, but where it's located is very strategic. It sits behind the maxillary sinus and above the palate, so it's encased in bone. So therefore, when you get the vibration, the bone vibrates and it can be modulated. So as a command center for the autonomics, it may relate not only to the vascular tone and how congested or decongested you are in the nose, but it also can regulate things like pain and headache. And actually, in my practice, I do sphenopalatine ganglion blocks endoscopically as part of my treatment for refractory migraine patients. And our pilot study, even though we didn't go down this path, our pilot study where we were monitoring pain outcomes because we wanted to make sure there wasn't an adverse effect of this treatment, we actually saw a lot of patients with comorbid headaches and and facial pain, and they were getting better too. And at the time, we didn't really know because we didn't really understand the mechanism. Could this all be related? But now when you go back and look at that data, it's very intriguing to think that there could be an application for pain and headache. And one of the interesting papers that I ran into recently when I was trying to understand this was there was a paper in the orthodontic literature about using vibration to manage the pain associated with tightening of braces, and vibration eased the pain. So, you see all this disparate data, you have to think, well, there must be something unifying about this. And it's intriguing that head and neck pain and head and neck, nasal symptoms. I mean, all these things could have a common underpinning.
It's interesting because, on those devices, those orthodontic devices, they've kind of fallen out of vogue because I feel like what they did was they were making a lot of promises that it was increasing the speed or the rate of tooth movement by changing the inflammatory cycle, the bone coupling mechanism. And one was called Accellident. Propel had another one. And they were trying to convince us, like, you'll treat cases faster. Like, tell your patients to change their Invisalign aligners faster. And I used some of them in my practice. What I found was the benefit that I liked the most about it was it really did take away soreness. I mean, legitimately. My 2 daughters went through ortho using it. And if they didn't use their vibration mouthpiece, they noticed differences in what their teeth felt like within the first couple days of an adjustment. And so, you're dead on. I mean, there was something there, and everyone kind of mocked these appliances like they don't really speed up movement. Again, the science I don't think was quite there on them, but they did provide a really nice comfort benefit, which is certainly a lot of my adult patients, especially, they really liked it, especially my aligner patients, because they would say, geez, if I'm traveling and I've got to give a talk or I'm doing something and I've got to change my aligners, my teeth are sore and it's just tough. So now this doesn't happen. And they would literally say they go through it pain free. So is it, and I guess kind of, Brian, you can tie in this as well. Are people noticing that, is there a particular phenotype that you find this works best for or better for? Or are there certain types, like I know, Peter, you'd mentioned that in sinus disease patients, chronic disease, it's not cleared to treat that and not treating that per se. It's working with the anatomy and helping improve nasal passageway patency. So are there particular phenotypes that do better with this, do worse with this, would you say? And Brian, you can start with that.
Oh, there's an interesting question. When we did our FDA randomized control trial, we actually did look at subgroups of allergic and non-allergic rhinitis. So there's a large group of people, especially as you get older, tend to get what we call vasomotor rhinitis, after you get runny nose, after it's cold, or after eating some hot food, spicy food, or temperature hot food, and that was of interest because a previous company Peter and I were involved with had a procedure where you would freeze the nerve, coming out of the sphenopalatine ganglion going to the turbinates. And that very much so helped vasomotor rhinitis. So the question is, are we impacting, allergic and non-allergic rhinitis? And our subgroup analysis seemed to be consistent across both groups, that it was actually impacting both, improving symptoms in both allergic and non-allergic rhinitis. And just to comment about the sinusitis, even though we don't have a specific indication, there's a lot of people feel congestion with sinusitis, right? So we really included people based on subjective symptoms of congestion, which, could have been in a prior diagnosis of rhinitis. And there's, as there's a huge overlap there, and people with rhinitis and sinusitis, hence chronic rhinosinusitis. It's to me, from my seeing these patients, looking at the studies, I think it's pretty broadly applicable across both allergic and non-allergic. What we haven't studied it for, which would be very fascinating, and I think it's on the list for the future, is congestion due to illness. You got your cold. I had a cold last week and my nose was stuffy and I used it and it helped me. But we haven't studied that yet. But Peter, would love to hear your thoughts.
Well, I think one of the intentional aspects of the design for us was this should be all comers with nasal congestion. And, in other studies that I do specific to sinusitis, we incorporate a nasal endoscopy. We want to look for somebody like you with polyps. We say, well, maybe you're not the right candidate, or somebody with a bad septal deviation. But in this study, because we really always wanted this to be available to consumers without a prescription, we needed it to be anybody who assesses themselves as having a problem with nasal congestion, which I think a lot of people know how to recognize. So we actually intentionally didn't eliminate people with deviated septums or sinusitis, and there were probably people in there, and yet we still showed that the clinical endpoints were met, and so we got our FDA indication as an over-the-counter device for both allergic and non-allergic rhinitis. And so I think that, when I think about the way that we designed the study and I talk to patients, I do tell them that, they should just try it because, in our study, we didn't screen out for a specific phenotype of people. And again, just talking to users of the device, one of our consultants I actually saw as a courtesy because he was told that he needed to have nasal airway surgery. And I agreed. I said, well, you've had everything, you've had all the medication, you have a physical narrowing of your airway. I think you're going to benefit from surgery. You should go ahead. I'm your second opinion. You should have the surgery. And he had just started using the headband. And I didn't see him for a year. But we just had this meeting where the consultants came and he's like, oh, Peter, guess what? I never had the surgery. Like, well, why? It's like, well, because after using the device long enough, my airway opened up. And his wife was with him and she's like, yeah, he doesn't snore anymore and he doesn't need surgery, and he wasn't using medications either. And I was flabbergasted because I actually saw him and told him he needed surgery to correct his nasal airway. So, that's just an isolated episode. But, there are going to be patients who are anatomically predisposed to congestion or other nasal complaints where still regulating their autonomic system and reducing parasympathetic inputs is going to be helpful to the degree that they don't feel that they need to have those anatomic abnormalities corrected.
Right. Yeah. And that's a great point too. And I mean, it's so minimally invasive that why not try before surgery, right? I mean, I guess, are there any, we can stay with you for a second on this, Peter, are there any significant risks or side effects that you noticed in your data set or empirically that you've seen since?
No, in fact, our prototype was using the bone conduction headphones that are not medical devices, but basically just emit audible sound waves. And so we went with a lot of confidence to FDA that there wouldn't be any adverse effects because all of this data is basically with, sound. So we didn't have any adverse effects. And I think, in general, I tell patients, give it a 2-week trial based on our data. We welcome any returns within 30 days. So we really want patients to give it a try, but also want them to know, there's no risk. We don't want you to feel like you just got taken with, we want you to be able to get your money back if it didn't work. But our return rates are really low. I mean, we are really happy with the efficacy that we're seeing out there.
Yeah, I mean, I think that's really the proof in the pudding. Typical consumer electronic device return rates are 20-25%, for devices like this. Ours are super low, below 10%. Our studies, both studies had a response rate about 80 to 90%. So across a couple of studies. So, that's consistent with the study response rate. So, very, very satisfying to see that. I mean, Peter and I will tell you, we were the biggest skeptics when we started this process, and now because the evidence just continues to be robust, we're believers and recommend this device to our friends and family.
Yeah, and do you find that with providers, let's say there's docs out there who want to start using this or recommending this to their patients, are there typical metrics that you would say they could measure that they kind of quantify other than the subjective assessment of the patient, which I'm a big believer is extremely important? And I can say personally, I noticed a difference. I said this on the part I did with Paramesh. The audience will hear this part twice, but so that you two can hear it as well. I noticed a difference. And I mean, my right side is my bad side. I'm sure you hear that from patients all the time. Whether it's the cycling on that side or whatever it is. And I hadn't really slept on my right side because we tend to sleep on the opposite side to allow that to open up, which actually, Peter, if you have time, maybe you could explain that to me better in a second. But I found that because my right side is my bad side, I would always have sleep on my left. And my wife said to me after probably a week of using it, she's like, I don't think you've slept on your right side the entire time we've been married. I've been married for over 20 years. So it's just interesting that was something that I now notice. I can literally sleep on my right side. So if you wouldn't, before we kind of wrap things up here, if you wouldn't mind explaining that, maybe just for my own curiosity, why is that?
Well, before, you probably had an equal amount of congestion on both sides and you might be narrower. it is actually interesting. I mean, it's kind of a bit of a sidebar, but we actually, first of all, there's dependent effects of just the side down getting more congested, right? And then lying down, there's more venous congestion under the blood. But there are theories that you have pressure receptors on the side of your body, so that if you're even standing up and leaning against a wall, the opposite side would probably open up. So, you know, it sounded ridiculous when I first heard it, again, when I was a resident, and one of these things I remembered, but now it's not so ridiculous anymore because...
It sort of makes sense evolutionarily, right?
Yeah.
You want to make sure people can still breathe when they're sleeping, right?
And so, you know, but then that's like autonomic regulation, right? Like pressure leads to a change in the autonomic inputs to your nose. So
Mike, you got to try sleeping standing up, leaning against the wall.
Perfect.
Yeah.
And then there's the nasal cycle, you know, which is the alternation of blood flow that also probably contributes too. But we're glad you're sleeping better. That's awesome.
No, I mean, it really has. Sorry, go ahead, Brent.
Oh, no, I was going to, your earlier question about what to track. So,
yeah, thank you.
I know I can hear Paramesh in my subconscious telling me, don't forget to mention this. You know, there's a couple of things. So one, in terms of dynamic airway, we can measure something called what we're calling Sonu check. So it's the nasalant. So we have a, again, software that can measure how nasal you sound. And that really seems to correlate with symptoms and findings. We've all had the experience, right? You pick up the phone. Well, I guess nobody uses the phone nowadays, but if you're like our age or older, you've used the phone and you hear somebody and you're like, oh, you sound stuffy, right? Right away, you know if they sound stuffy.
Yep.
So, you know, the computer can pick that up. And then, you know, anatomically, we have a high correlations in terms of data between, you know, people who are at risk. So people with, you know, narrower noses, certain anatomic features. So we've got that fixed anatomy. We can provide an assessment. So these are assessments, of course, we really like to provide for the providers because they are sophisticated and know what to do with it. You know, the FDA doesn't allow us to, you know, make diagnoses for patients. So that's not what we're doing. It's a decision support tool. Hey, you know, Dr. DeLuke, you've got this patient with this anatomy and falls into this category. Or, hey, this patient has more congestion today based on this nasalance. And then, you know, giving you options of what to do or what that may mean. So those are kind of two factors in what we could measure for providers in the long term using the app.
Okay. Yeah. And that interface, as Paramesh was describing too, is only growing. And I had to first scan my face because there is a component of the structural anatomy that you, correct me if I'm wrong, cross-reference with a lot of CBCT data, correct, in the beginning?
Exactly. Yeah.
To get that, and then there's a very high accuracy there, plus the resonance that you're able to develop that. And is it a custom frequency? That's kind of my own. Sorry, I'm asking these questions. I wonder as I'm using it, but I guess a lot of people out there using it might
custom.
have them. Is it so? Is it adjusting it to me as it reads, as I read, man? Simmers on the moon, and is it sensing?
So for that part is not yet. It's not dynamically altering. So that, again, just because of the way the FDA works, there's a certain things we can't do dynamically yet. Okay. But it is custom for you based on your anatomy. So, you know, we're all different. Peter and I always are fighting about who has the biggest head. Both figuratively and literally. But, you know, your head size really, you know, your resonance, how deep your voice is, right? So, you know, like my wife is a small head, you know, her resonant frequency is much higher than my resonant frequency. Because I've got a bigger head, bigger sinuses, you know, bigger nasal passages. So yeah, that customization and that personalization with the face scan is really important.
Interesting. So the last thing to close it up is what can we expect going forward that you can talk about? Where is this going? What can we look forward to in the future with this type of theragnostics and even resonance approach?
Yeah, I mean, one area we're looking at is the pain, you know, facial pain, headaches. As Peter mentioned, in our first trial, we didn't, you know, select for people with headache, but in those patients with facial pain, it seemed to improve. So that was a positive sign. And you can imagine how many people have headaches and facial pain out there. So really excited about that. Right now we have pediatric indication 12 plus. So we are considering, you know, we'd probably have to change the form factor because kids are small, to look at expanding that indication to younger children.
Anything you want to add to that, Peter?
I think, yeah, well, definitely the number of diagnoses that we can treat with this will probably evolve with time. So sinusitis, you know, Mike, like you would be the perfect patient for a study for us where, even though we're not necessarily treating your sinus pathophysiology, we're treating your symptoms. And I bet you we could show that people like you could benefit from Sonu. And so, that's another group of patients that I think really could benefit, that we just need to do the studies. I mean, as a startup, we can only, put our attention to so many buckets, but that's definitely on my list. Other indications, for example, rhinitis of pregnancy is common, and most women who go to their OBs and say, I can't breathe through my nose, they're going to say, well, have the baby and it'll take care of itself, because nobody will use medications, new medications during pregnancy. So that's another indication where maybe we're going to see interest in using this kind of device. I do think with the kids, just as Bryant said, I think a lot of parents just don't love the idea that you have to use nasal steroids for your kid for something like this. And, my daughter right now she just had to start a steroid inhaler for asthma. And I don't love the idea that her physician says, it's fine, use it every night. We're naturally, even as somebody that understands that steroids, have a certain safety profile, I don't love that idea. And so for lots of parents, they're just concerned about how dependent their kids may be on medication. So I think there's a lot there. As Brian said, we are indicated for 12 and up. But my kids who are under 12 use this device happily. So I think the safety is going to be just a matter of meeting FDA indications. And then Brian,
that's off-label. That's off-label. We're not recommending it.
That's right.
Right. Use your own risk.
Brian, sleep. You want to finish on sleep, Brian?
Oh, yeah. So, we have a sleep product which is related to Sonu. We call it Spatial Sleep.
Okay.
And what it does is it uses your cranial resonance to entrain your brain waves to help you get down to theta sleep. And we did a big study with a huge drop in insomnia severity index. Right now it's a sleep aid. It's not FDA approved. So it's a sleep aid, helps you sleep, but we are going to do a randomized clinical trial later this year and apply for FDA approval.
Wow, exciting stuff. This is great. It's so fun. And what's so great about it is you're both trained more traditionally, as myself, right? And but we probably similar ages, and we trained years ago before technology was even close to what it was today. And I love when people of our genre are not just continuing to do it the way we were taught. And we are pushing that envelope of using the technology, not solely the technology. We have to rely on our fundamentals in anatomy and the overall pathophysiology of disease. We can't just abandon that. We could take that, though, and use that. I mean, it's really limitless what we can do with our knowledge and our ability with technology. And I just love listening to people as intelligent as the three of you two and Paramesh. And I just can't thank you enough for taking your time to come on the show and for continuing to be innovators as well as busy clinicians, because I know that being there myself, it is not an easy thing to do. So I really genuinely appreciate it. How can people reach you or find out more about it? I'll certainly put a link to Sonu in the show notes, but anything else that people have other questions?
Go to soundhealth.life. You can read all about Sonu there. And then if you're interested in the can't call it the insomnia product, but our sleep aid product, which hopefully will have FDA approval later, you can go to spatialsleep.com.
Anything else, Peter, for you, or just through that same context?
Yeah. Thanks for your interest, and thanks for having us.
Yeah, it's my pleasure. Dr. Peter Hwang, Dr. Bryant Lin, absolute pleasure. Thanks so much. Really enjoyed speaking with you, and thanks for taking the time to come on the show today.
Fantastic. Thanks for having me.
All right. Bye-bye. Thank you for tuning into this episode of the Doc Podcast. Be sure to visit theorthocoach.com to get access to ADA CERP recognized CE courses or to schedule a private one-on-one coaching session with me. Also, if you know of someone who would make a great guest for this show, or if you'd like to be a guest yourself, please email me at drmike@theorthocoach.com. And be sure to join the Doc community on Facebook for more great content. Thanks so much for listening, and always remember, you have been blessed with the ability to do amazing things.